Hello, everyone. I am very pleased to welcome you to this evening's alma mater event, Parenting with Anxiety. My name is Jessica Muss, Barnard class of 1998. I am chair of the Alma Maters Committee of the Alumni Association of Barnard College. The mission of Alma Maters is to provide mothers with thoughtful discussion and programming on all aspects of parenting and work-life balance by hosting presentations, workshops, and discussions that span the years of parenting from prenatal to college-age children. As a reminder, you will not have microphone or camera access during this online event. Attendees' voices, likeness, or images will not be captured by Barnard College. Written submission of questions may be shared during the Q&A portion of this event. I am delighted to introduce Dr. Michael Wheaton, Assistant Professor of Psychology who joined Barnard's faculty in 2017. Prior to coming to Barnard, Dr. Wheaton was a postdoctoral clinical researcher in the Anxiety Disorders Clinic at the New York State Psychiatric Institute, and he previously taught at Yeshiva University. His research interests focus on the psychopathology and treatment of obsessive compulsive disorder, OCD, and OCD-related disorders, with a particular emphasis on behavioral therapy. He is a licensed psychologist in New York State and teaches classes in abnormal psychology and clinical psychology at Barnard. I now turn the program over to you, Dr. Wheaton. Thank you for joining us this evening.
Okay, great. Thank you so much. So now I'm going to, just as we did in our practice, I'm going to try to share my screen, and I'm going to start this slideshow, and then I'm going to, I'm going to try to pull up the chat just in case somebody needs to chat me if there's an issue. Okay, so thank you so much. So I want to thank Jessica for inviting me to come and speak with you all today for a discussion of parenting with anxiety, but also providing an overview of sort of the research that I'm doing here at Barnard College, where I am so happy to be since 2017. So I am a licensed clinical psychologist, and by training, I'm a CBT therapist. I'm a cognitive behavioral therapist. And so CBT people, we always make an agenda. So I wanted to make an agenda for what we would cover today. The first part was just that introduction from Jessica, so thank you so much for that. And then I have some slides. So I'm hoping to go through the slides that I have today in about a half an hour, where I will give an overview on the emotion of anxiety and then the category of illnesses of the anxiety disorders, introduce you to or provide an overview of some of the research that I've been doing with Barnard students here on OCD, and then we can open up for a discussion relevant to y'all's group on anxiety around parenting and what that means and how the insights that we gain from studying anxiety disorders might be relevant. So moving ahead with the presentation, I'm going to keep track of time for myself. So anxiety is interesting. Anxiety is sort of a universal emotion that all human beings have from time to time. So it is an emotional state that's characterized by physical tension and typically apprehension about the future. It's usually future-oriented to potential threats that may or may not materialize. And then we can break it down into what's happening when a person is experiencing anxiety according to three levels. So at the physical level, physiologically, what's happening in your body when you're feeling the anxious emotion is characterized by a lot of muscle tension, physical unease. It's sort of like your body is becoming a spring that is coiling up, getting ready for action, should you need to go into action mode. So a lot of muscle tension. On the cognitive level, what's going through your mind at that moment, that's what cognitive would mean, is an alertness of your attention. Your attention is sort of focusing particularly to scan the environment or think about potential threats or worst case scenarios. What's a scary thing that may or may not happen? And then the behaviors that go along with feeling anxious often are sort of freezing, not really acting, or preparation for action, like getting ready to flee should you need to flee, or sort of scanning for threats. So it's sort of an apprehensive emotion about something that hasn't yet happened, but might happen. And that's where your mind is going to. Whereas fear sort of a distinct emotion that's a little bit more intense than anxiety, which is now your body is reacting as if a threat is not possible, it's present, it's here. Whatever it is that you're afraid of is now present, and you have to deal with it. You have to deal with it either by fighting back, or trying to escape, trying to flee. So this is where your body's activating the fight or flight response, which gives you this rush of physiological arousal oriented to your sympathetic nervous system. So your heart is pumping, and your pupils are dilating, and you are having funny feelings in your stomach. Actually, what's happening is your body is trying to get all of the oxygenated blood to go to your big muscle groups to get ready to run away or to fight back. And so that can make changes happen in your blood flow. So your stomach is sort of doing somersaults, or having butterflies in your stomach is actually happening related to where oxygenated blood is going. Your body doesn't want to be digesting food at that moment, wants to be preparing to flee. Same with some things that can happen inside your own mind. You might feel a little bit dizzy, woozy, lightheaded. Again, it's a change in oxygenated blood flow. And some people will feel a little bit disconnected from reality, like which we would call dissociation. Importantly, this intense reaction is very costly to your body to produce that. Like, that takes an enormous amount of energy. And so your body can't sustain that level of physiological arousal for long. And it has a brake system, which is called the parasympathetic nervous system, which is designed to kind of slow your body down, assuming that if there was a danger present, you must have escaped it by now. And so we have the fight or flight system for fear, and we have the rest and digest system to calm down after fear. Okay, so fear and anxiety are sort of distinct emotions, but they overlap a lot. Fear is more present-oriented with a lot of physical arousal, whereas anxiety is much more future-oriented about a potential threat that hasn't yet materialized, but it might. But the anxiety disorders often involve one or another, or a combination of them, and sometimes they feed into one another. You have an intense bout of fear, sometimes we call a panic attack. You might be anxious about having another one in the future. So you might worry about having a future anxiety attack or a panic attack. So distinct emotions, but they often go together. A key thing that's worth talking about with both anxiety and fear is that they can be good in doses. Sorry, I skipped a slide. They can be good in doses in the sense that, we evolved these emotions for a reason. Often they're there to protect us from danger, or to help us focus on something that is important to focus on. And there's a famous psychological finding that they call the Yerkes-Dodson performance curve, which is the sort of U-shaped, inverted U-shaped curve for how much anxiety or anxious arousal you're feeling and how much you perform on all different metrics of performance, be it academic, giving a speech, sports performance, that typically, if you have a moderate amount of anxiety, can actually help you, can help you focus, take it seriously. If it's a test that you need to study for, if you're not feeling anxious at all about it, you might blow it off. You're not going to study for it. You're not going to take it seriously, and then your performance might be quite low on the test. However, if your anxiety is too high about the test, you might be so anxious about it that the day of the test, you can't focus. You're missing items that you actually know the answer to because the anxiety's gone too far. Or anxiety was so intense when you tried to study, you couldn't deal with it, so you shut the book and set it aside and didn't study. So often it's the case that a middle amount of anxiety, a moderate amount of anxiety, is actually associated with improved performance. So the key thing is that we think of anxiety as a normal emotion and sometimes a helpful emotion. It's just that it can sometimes go too far. And so this is the idea that anxiety can be either adaptive or maladaptive. Adaptive is like evolution, Darwinian evolution, and adaptation is something that helps the organism. So adaptive anxiety is anxiety that helps you, right? It may help you under certain circumstances, that it's a realistic concern, that if you are camping in the woods and a rattlesnake slithers through your campsite, hopefully you feel anxious, because that anxiety will make you pay attention to get out of there, to get away from the danger, and it may help you to actually flee faster. Adaptive anxiety typically, though, is experienced in proportion to the nature of the threat that's making you feel anxious. So a dangerous snake, it makes sense to have a great deal of anxiety. A snake that's not that dangerous, we don't need to be that anxious about. And helpful or adaptive anxiety typically passes when the perceived threat abates. But once you're back, we're back to safety, the anxiety diminishes. Whereas maladaptive anxiety, anxiety that is not helpful, that's actively harmful, interfering in your life in an important way, is often where it is an unrealistic concern. Like, for example, instead of fearing a rattlesnake when one is present on a camping trip, fearing rattlesnakes here in the city where there aren't that many snakes. So it would be an unrealistic concern, or a fear that is out of proportion to the nature of the threat, or a fear that either comes on way too early, so you're just anticipating something far in advance and suffering well before the event, or even after the event is over, you still feel anxious about it. So the anxiety would be persisting afterwards. So all of these different ways that anxiety could be maladaptive or unhelpful. And then what we have that I teach in my class on abnormal psychology, abnormal behavior, is a category of illnesses called the anxiety disorders. These are characterized by pervasive patterns of maladaptive anxiety and or fear that causes significant distress for the person. Like, the magnitude of how intense the emotion is so high that it rises past a clinical severity level, or, and typically it's and or, it leads to impairment in the person's life, that it is interfering in their ability to get their schoolwork done, or it is making it more difficult to hold a job, or they're having their social life impaired because of the anxiety. So problematic anxiety, or pathological anxiety, we would call it. And then which are the anxiety disorders as they're classified? We have the DSM, the Diagnostic and Statistical Manual, that lists all of the anxiety disorders. So we have specific phobias, where it's a particular category of stimulus that the person has a phobic reaction to. Generalized anxiety disorder is not a particular thing that person is anxious about. It's maybe a wide range of different things that they worry about, and predominantly worrying about the future rather than having panic attacks, which would be the next illness, panic disorder, where a person's having recurrent instances of really intense bouts of fear that come on sometimes unexpectedly or out of the blue, and interfere with the person's life. Social anxiety, which is where a person is afraid of negative evaluation from social people. It could be specific to certain situations, like giving a speech in front of class, or it could be a more generalized form of social anxiety, if social interactions in general provoke anxiety. And then two conditions that were previously thought to pretty much exclusively happen in children, but now it's recognized they can happen in adults too, are separation anxiety, which is where you're afraid of being separated from close attachment figures, and selective mutism, which is where it's really hard to produce sounds of speech, even though you're capable of producing speech. And formerly, the disorder that I spent most of my time studying, obsessive compulsive disorder, was classified as an anxiety disorder, although it actually no longer is. It has its own category. So I'll just spend just a few minutes talking about what OCD is before I give an overview of my work in this area. So OCD is characterized by obsessions and compulsions, where obsessions are repetitive thoughts, images, or urges that pop into a person's mind when they don't want them to be there and provoke anxiety, distress, or uncomfortable feelings. And then compulsions would be repetitive behaviors or mental acts that the person feels driven or compelled to do to relieve anxiety or distress, or to prevent something bad from happening, or just has to be done a certain way according to rigid rules. And typically OCD has different symptom dimensions for prototypical obsessions and compulsions. So often it's about a fear of contamination, like a fear of contracting an illness from dirt or germs in the environment, that would then be coupled with washing rituals, like excessive hand washing, excessive showering. Sometimes it's a fear of making a mistake, like what if I left the stove turned on and the apartment burned down? What if I left the door unlocked and there was a burglary? And those often go along with checking rituals or checking compulsions. Let me go back and check the door. Let me just go back and check the stove. Sometimes it's a fear of unacceptable thoughts, like what if I somehow don't intend to do it, but what if it turns out I'm a violent person and I had a thought, like what if I pushed someone in front of a subway train? And then the last category would be for symmetry, ordering, and arranging OCD, which is where a person is sort of preoccupied with the way things look and feel. It needs to be a certain way. Things should be organized and arranged just so sometimes because there's sort of a superstitious fear, something bad may happen if not, or sometimes just because it doesn't really feel right, it doesn't really look right unless it's just so. So it's not only anxiety and fear involved in OCD, sometimes it's other emotions like disgust or what we call a not just right experience, that it just doesn't feel right. And that's actually why they took it away from the anxiety disorders, because it's not only anxiety that people with OCD experience. The good news, though, for people who are families where someone suffers from OCD is there are good treatments available for OCD, which we call evidence-based treatments. On the medication side, there's a category of the selective serotonin reuptake inhibitors and one older non-selective serotonin reuptake inhibitor named clomipramine that are all FDA approved to treat OCD, including in kids and adolescents. And they typically help people, but in a partial way. That on average, people taking these medications find that they relieve symptoms by about 35%. So they sort of take the edge off. But when you're suffering from OCD, you'd be glad for any benefit. But typically, it's only a partial response. And then on the side that I do is the CBT side, the psychotherapy side, is actually just as, if not more effective than medications for treating OCD, is a particular form of CBT, cognitive behavioral therapy, that's called exposure and ritual prevention, or sometimes it's called exposure and response prevention. So what's happening in this form of therapy is it's a very active behavioral therapy that is present-oriented, where we are working with people who have OCD to try to confront the situations that provoke obsessions without doing compulsions. So we do exposure therapy, confronting fears, stimulation, and situations. At the same time, we do response prevention, meaning trying to refrain from engaging in compulsive behaviors. And really what we're trying to do is very much like a facing your fears type of treatment, is to be breaking the association between whatever that initial thought or image or situation was and the anxiety that followed it, and trying to break the association between relying on compulsions as a way to feel better. Because typically, the types of situations that people are having obsessions about, and anxiety in that situation is often a false alarm, meaning that they're reacting to something that is unlikely to be as dangerous as they perceive it to be. And so we're just trying to recalibrate the alarm system by facing it and saying, oh, maybe I don't need to go back and check the door. Maybe it's unlikely that I will have left the door unlocked. Or even if I did leave the door unlocked, maybe it wouldn't be as bad as I feared. So it's a present-oriented therapy of changing behavior, but also it helps to change people's underlying beliefs and appraisal of danger. And it can be delivered in a pretty brief format. So you typically 15 to 20 sessions, sometimes deliver 2 times a week, which means the way they've tested this in treatment trials is you could do the whole treatment in about 2 months if you were doing it at that schedule. And there's really good evidence that this is a treatment that's highly effective for people. It's often considered to be a gold standard treatment for OCD, and it's recommended in practice guidelines that are used by psychiatrists and psychologists, including the APA's, American Psychiatric Association's practice guidelines, and over in the UK, where they have a nationalized healthcare system, the guidelines that they give for treating OCD recommend start with behavioral therapy even before you try medications, because the evidence would suggest it might be enough just on its own to change behavior. So it is the recommended gold standard treatment. However, this form of treatment is not universally effective. So not everybody fully benefits from ERP. It's perhaps up to half of people who, after a typical standard dose of ERP, are still experiencing, even if they've experienced therapeutic benefit, they may still be experiencing some remaining symptoms that are problematic. And then there's maybe another group of up to 20 or 25% of people who don't experience benefit from ERP. So that's what my research is all about here at Barnard, is trying to improve this treatment and to disseminate it. Because the other problem with this treatment is maybe not everyone has access to it. Not everyone is able to find an expert who knows how to do this treatment. So my research is to give you a snapshot of what it's been all about. One of the things I'm primarily interested in is trying to understand, well, if we know this treatment doesn't work equally well for everyone, could we try to predict and understand treatments when it's not working? Like, why is it working so great for some people, and why for other folks is it leading to poor outcomes? So some of the factors I've looked at in my research have been, for example, avoidance behaviors, which is where a person not is doing obsessions and compulsions, but is avoiding the world in a significant way, sometimes so severely they could become basically homebound and have real difficulty going out in public, being around other people. And what we found in this study was that the more severe the avoidance of the world was, the worse the therapy outcomes were. In another study, we looked at perfectionism as being sort of a factor that could relate to the development of OCD. But here in this study, we found that having perfectionism didn't prevent people from doing well in treatment. What was really interesting was that it was a change in perfectionism that determined whether you did well in treatment or not. So if you had perfectionistic standards and ideals, but you were willing to modify those, and there was improvement in perfectionism, that predicted improvement in OCD symptoms. And then the last study, the most recent one that we did, was looking at, this is a therapy that is delivered with the individual experiencing OCD and their treatment provider, their therapist. And what develops between the two is a therapeutic working relationship. How do you relate to one another? How do you agree on what your goals are? Do you form a therapeutic bond? And so we tried to study the strength of that relationship to see if it would predict how much improvement people got. And we did find that the ratings of how strong the relationship were did account for how much better people got in therapy. In particular, whether there was a discrepancy, whether one party in the dyad was seeing the relationship as flawed in some way while the other party wasn't, was a strong predictor of whether there would be a therapeutic treatment response. And then just to highlight some of the work that my students have been doing with me on my research team, obviously, the COVID pandemic happened in the past 3 years while I've been here at Barnard. It totally affected our research program, but it also was an opportunity to try to use what we study and know about OCD to understand what was going to happen and how people responded to this virus threat, because one of the major fears in OCD is fear of germs and contamination and contracting an illness and compulsive washing. And then we had this real world threat. So we were doing research studies to try to understand in people with OCD, what was this going to be like for them? So we did a study with me and a team of students where we asked people with OCD how COVID was affecting them. And we did this qualitative analysis to figure out what the effect was of COVID on individuals with OCD. But we also looked beyond OCD, just in the general population, and found that many people were developing fear of COVID and including developing OCD symptoms. People who perhaps did not have OCD before COVID came along. So we did a few studies to identify factors that were related to that. And I think in the interest of time, I'll have to just sort of move on from them. And then what we're currently working on, so right now I have a project that's a collaboration with Barnard's IMATS office, which does all sorts of audiovisual recording. And we got a small grant to basically develop training videos to try to train more therapists to be able to deliver this form of therapy. So we recruited an expert in this form of therapy, had him role play exercises that come from the therapy with IMATS students, staff filming it. And now we're editing the filmed tapes, and we're going to disseminate it to graduate training programs in clinical psychology so they could have easier access to training materials to learn how to do this therapy. I also, just highlighted, have a project happening with students right now, and the students are always so good at coming up with great ideas. And they came up with this idea, sustainability is such a big thing on Barnard's campus. We have a big effort for sustainability. Well, one of the things that might make sustainability practices hard is people who are afraid of contamination. If you're afraid of contamination, are you really going to buy recycled clothes that have been previously worn by someone else? So we have a small grant from Barnard's Climate Action Program to try to study this, to see is a person's sensitivity to the emotion of disgust and their OCD symptoms going to make it more difficult to want to participate in the secondhand economy of used items, used clothing, and that sort of thing. And then the last study I'll just mention is we're doing a study to try to overcome perfectionism in our students by practicing self-compassion. So we're doing that study just this current semester, actually. Okay, and then finally coming around, and we're pretty much right on time to talk about what's relevant to this group, would be parenting and anxiety. And of course, like being a parent, there's going to be anxiety. And just to make a distinction that Jessica thought was really important to make is like, what is the distinction between a worry and an obsession? Because they sort of feel like they could be synonymous, but they're actually slightly different. So the way we think of obsessions and OCD is that they're repetitive thoughts that aren't necessarily the same exact thought every time, but they typically gravitate around a particular theme, like the fear of contracting an illness or the fear of being responsible for harm to another person. And often that theme that they connect to is a little bit disconnected from day-to-day concerns, although with COVID wasn't so disconnected from day-to-day concerns. But the obsessions tend to be circular in that it's the same flavor over and over and again, and that they're repetitive. Whereas worries can shift from day to day, from moment to moment. That is, at one moment, it's a worry about, well, will I make it to my appointment on time? I put a check in the mail, will it arrive on time? Will I have enough money at the end of the month? What about my parents' health? What about my kids' health? So worry tends to shift from one imagined negative outcome to another potential catastrophe, and sort of is a moving target, shifting and evolving over time, and typically oriented towards the future. Not necessarily that it is happening now, but that it might happen in the future. And anxiety involved in parenting, I would assume, involves a lot of worries because there are so many unknowns with being a parent and so many things that could go wrong or might not go wrong. And many situations that would probably ask for a moderate amount of anxiety to think, okay, this is something that's worth considering, focusing on, dealing with, handling, but that the anxiety could easily go too far to really just considering the worst case scenario. And then we could talk about some of the strategies that maybe we would use to try to rein in or examine parenting anxiety during parenting. So one of the tools that we use therapeutically is this self-reflection tool that's called Observe, Describe, Participate, which is the idea of taking a moment when you're feeling anxious to really just observe the situation that you're in the way that an outside observer was, to comment on like actually what is happening in that moment, to just first observe like the situation, then to describe the situation, particularly if you're a person prone to worry, trying to catch yourself, oh, there I go worrying again. And then to participate in the situation in a way that you're choosing to participate rather than a way that anxiety is driving you to participate, rather than a way that's aimed at escaping from anxiety. We also would want to address some what we would call maladaptive beliefs about worry. Sometimes, particularly in folks with GAD or generalized anxiety, there are these sort of funny ideas that, well, maybe actually worrying is a good thing, right? Wouldn't that indicate that like I care? So maybe worrying is a good thing because it shows that I care. And we can sort of challenge that notion by, as it relates to parenting, this comes up all the time, but isn't that the job of a mom is to worry? That would say, actually, well, let's think of like one of your friends who you consider to be a great parent. And then think like, well, what are the characteristics that you would associate with that person being a great parent? And usually it's things like, you know, does fun activities with their kids, or always picks up the kids from school, or really listens to the kids and knows what's going on in their lives. And then nowhere in there, in the description of what makes that person a good parent, is stays up for 1 or 2 hours every night, unable to sleep because of thinking about worries of what could happen last, or what could happen next. And so challenging the idea that worry is a good thing, or challenging the idea, well, worry might be a good thing. It might help me prepare. I'm anticipating future calamities as if like, then I'll be ready for them. Then I'll be able to defend myself. And then I'll be able to manage it. And we can challenge that by saying, well, typically the things we're worrying about, ultimately, most of them don't come to pass. And so it's a lot of preparation for stuff that doesn't come to pass. It's sort of like wasted effort. And then we say also, is there anything unpleasant, aversive that you had to deal with that you didn't worry about? You didn't anticipate it. You didn't think it was going to happen. It just sort of happened out of the blue. And most people can say, oh yeah, like I didn't worry that my car was going to break down, but it happened. oh, you didn't anticipate it and worry about it, but were you able to manage it? Were you able to respond to it appropriately, even though you hadn't anticipated it? Most people would say, well, it was stressful, but I figured it out. And I would say, okay, so maybe you're actually capable of figuring things out without planning them all in advance or worrying about them. Or you might also give people tools of just sort of recognizing that pendulum, that anxiety can be too little, it can be too much, but we want to be in the middle, but asking, is this going too far? Like, reflecting on, is my anxiety really pushed up to one side that has now gone beyond? And sometimes we would ask questions like, am I actually confusing possibility with probability? That just because something is technically possible doesn't necessarily mean it's probable. It doesn't mean it's going to happen. And one of the tools we try to help people with is to think about, well, when we're anxious, when we're worried, it's usually pretty easy to conjure up, like, what's the worst case scenario that I'm worrying about here? And we also like to say, okay, that was easy for you to think of, like the worst case scenario that came into your mind pretty quickly, probably because anxiety made that much more available to you. But what if you stepped outside of that and said, well, actually, what are the other possibilities? What is the best case possibility? And that's usually pretty far to the extreme. You have to make yourself do work to think of what's the best case. And then we can ask another question of well, actually, what's the most likely scenario? Because usually it's somewhere in between. It's usually not the worst case. It's also not the best case, somewhere in between. So what is the most likely scenario? And could I stand that? Could I manage that? We can also help people try to control worries by compartmentalizing them. So often worries are hard when they feel like they're taking over. I'm worrying constantly. It can be helpful to ask that question that's there, is this the right time to worry about this? Is this not even just worry about this? Is this the right time to work on this? If this is a problem that requires my attention to deal with, is this the moment I'm going to effectively deal with it? Because if not, we could do something we call a worry window, where we say, let's schedule a time to deal with these issues that we're worrying about, but in a compartmentalized way, and in a way that when we're dealing with it, we're not just passively thinking about how bad it would be and what would happen next, but we're having a blank piece of paper and thinking if I treat this as a problem to be solved, what would I do about it? And then the last thing would be to talk about the way that we can, what we call, regulate our emotions so that they are not driving us. So sometimes we want to practice what we call emotional acceptance, which would be the recognition that, well, anxiety is actually not a problem if we treat it as, this is an emotion that I'm feeling. And sometimes we try to think of our emotions coming and going like waves. And we sometimes think of accepting them as being a buoy in the ocean. We're in the ocean, and a wave comes. What actually happens to the buoy? The buoy doesn't really move. It just goes up and down. And the wave passes underneath the buoy, and then the buoy goes back to where it was. So we try to work on seeing our emotions that way, that we accept them. We can also practice soothing techniques. And I think Jessica was interested in talking about meditation as a way to maybe cope with emotions. And then we also talk about trying to keep an even keel emotionally, knowing that we're more vulnerable to emotions like anxiety when we're not getting sleep, or when we're not eating regular meals, or getting regular exercise, or consuming too much caffeine. So trying to keep just a balanced, even keel as a general strategy to regulate emotions. Okay, so I think I'm right on time. Those were all of the slides that I had, and now maybe we could get to sort of a group discussion, or a discussion of questions that came up.
Fantastic. Wow. Thank you so much. This has been so informative. And yeah, everybody feel free to send your questions and answers to our Q&A. Dr. Wheaton, when should parents become concerned with a child's perfectionistic behavior? Say they've been that way always. When is this a source of concern?
Sure. Well, so I think it's one of those things that's good in doses. Actually, this is one of the things that my research team here at Barnard is sort of studying, is perfectionism. And perfectionism has different facets. there's one, and perfectionism is a funny one because people say, like, is perfectionism really a problem? Because like maybe it's a good thing to be perfectionistic because that drives me to do well. So actually, there's adaptive forms of perfectionism and maladaptive forms of perfectionism, the same way that there's adaptive anxiety and maladaptive anxiety. So the adaptive form of perfectionism is maybe it's good to be a striver. It's good to have high standards to like yearn to achieve. And that actually can be a good thing. Like there's a lot of high performing people who have those sorts of traits. But where perfectionism becomes maladaptive or problematic perfectionism is where there's a difficult time resolving the discrepancy that comes from, I have my ideal world of how I'd like it to be, and then I have the real world of how it is. And if I can't resolve that discrepancy in a healthy way, then I'm going to feel very upset, or I'm going to engage in avoidance behavior. Or like, for example, there's the saying, don't let the perfect be the enemy of the good, that we use a lot in therapy. Of this happens to students all the time. I'm working on an essay. I want it to be perfect. That was my goal. That's my striving, is to be perfect. But it's due tomorrow morning, and I know I don't have enough time to make it perfect. I know it's not going to be perfect, and I can't stand to be less than my goal. That discrepancy that would be there is something I can't cope with. So what am I going to do? I'm not going to turn it in. I'm not going to turn it in because I don't want to face that discrepancy that I have performed below where I was hoping to perform. And then actually it's going to get even worse, because now instead of, okay, it wasn't a perfect paper, but it was a B+ paper. Well, now I don't have a paper, and I'm an instructor of a course, and I have to record a grade for you, but I don't have a paper. I'm going to have to put a 0. So actually the perfectionism backfired. And so that's where we always look for, is this helping or hurting? And the idea, the way to figure it out is like, is it really helping me, or is that actually interfering, causing problems, getting in the way? And as a parent, I suppose hopefully like that would become apparent where the perfectionism is starting to interfere, and then trying to help a person see that the discrepancy between the ideal and the real world performance is something that like we try to work on practicing acceptance, right? Like, well, okay, this time was a B+, and yeah, you're striving for A+, but you know what? Like this is a learning experience, and we move on, we accept it. Jessica, were there other questions, or do you want me to look in the ones that came in the chat?
We're good. Feel free, but I can also keep asking you questions, whatever you prefer. What is the typical age of an anxiety disorder onset?
That's a great question. And actually, like someone pointed this out, it's like a truism about talking to a psychologist, particularly a clinical psychologist. If you ask us a question, almost always the answer is going to be, it depends, right? It's very hard to get a straight answer from us. So what the age of onset for the anxiety disorders, it depends on which anxiety disorder. Specific phobias start the earliest. They typically have an early age of onset of like 7 to 8 years old. Some of the other anxiety disorders start later. So panic disorder, generalized anxiety disorder, they come a little bit later into adolescence, more rare in younger kids. Social anxiety starts pretty early too. So maybe that one happens a lot around school transition ages, like middle school years, middle school to high school years, can start a little bit earlier, could start a little bit later. But social anxiety typically is a condition that starts in childhood or early adolescence. And then OCD is interesting. For OCD, we say it has a bimodal distribution, sort of 2 humps in terms of when people have a typical onset. So there's a younger hump for childhood onset OCD, which is actually more common in boys than in girls. In general, the prevalence rate is equal for men and for women, for boys and for males and females. But boys tend to have a younger age of onset. And then the second mode tends to be around 19 to 21 years old. So it's either early, like the childhood OCD, or adolescent OCD.
Great, thank you. Would you be able to share with us, as somebody who is at a very amazing college named Barnard, what accommodations can people advocate for their children with OCD at specifically a college level?
Sure. So, well, that like Barnard has a great Office of Disability Services. I think they changed their name though. They're no longer ODS. But they are great, and they do individualized assessments for students for what type of accommodation will help the student to learn the best. That's what it's really about. Like, is the student able to meet the the learning objectives of the course? What accommodations will help them to do that? So accommodations that I have seen commonly are things like taking exams in a distraction-free testing environment. If it would be overwhelming, like if you get anxious during an exam or you have attentional difficulty during an exam, and you're in this giant classroom where maybe someone in the front is coughing and there's all this noise and like your anxiety's through the roof, having the exam in a distraction-free environment, sometimes having extra time on exams, those can be really helpful. Sometimes actually what they'll write into an accommodation plan is for the person to reach out to the instructor if they need an extension on an assignment or if they're struggling with an assignment. And that can be really effective. When it comes to that issue though, of I get perfectionistic about something, and then because I'm so afraid of failing that I don't turn it in, having accommodations that give extensions can be wonderful because it's like, okay, you get a little bit more time, but then you just want to be careful not to overuse them to get in the habit of like, okay, well, I know the deadline is here, but I can use my accommodation to get extra time. And then wait, well, now I use my accommodation in that class, but I also have this other class. So now I've like sort of stacked everything to be due at the same time. And then it really gets tough. So I think sparing use of the accommodations can be helpful.
Great, thank you. There was a recent article in the New York Times titled, "What if kids are sad and stressed because their parents are?" Would you share one or two of the most helpful methods you have seen that help to prevent a parent from contributing to their children's anxieties? That is something that is fairly easy to implement at home.
Yeah, that's a great question. I mean, I think it would be, we talk a lot about like role modeling, right? Like is because some of these conditions, there's a substantial genetic component to anxiety, but there's also a shared environment component to anxiety in it. So it can be a role modeling exercise. And maybe this is, I don't think I actually read the article, but probably what it's talking about is if a parent is sort of radiating with anxiety, is that going to seep into the child's mind, learning that like, well, the world is stressful. Like my parents stressed out all the time, implicitly, I'm going to learn that the world is stressful, right? But I think we also don't want to send the message that anxiety is bad and we can't feel anxious. What's probably the best way to role model is like, oh, sometimes I worry about this, but when I catch myself seeing, oh, okay, that's not something that's a realistic concern. Here's how we together, and then typically we talk about approach. Instead of avoidance, we approach.
Great. If you are a parent with an anxiety disorder or OCD, is it genetically more likely that your child will also develop an anxiety disorder or OCD in particular?
So yes, as I mentioned, like there is research on genetic linkage study that find that these conditions often do have a heritable component to them, but the heritable component for conditions like anxiety and OCD is less than for other conditions. It's less than for traits such as IQ or things like that. So there's a potential, but there's also a substantial factors that are unaccounted for by genetics, including shared environment, lived experiences that you may have. So certainly we would not want to send the message that, well, if I have OCD, my kid's definitely going to have it, because that's not true. It's not true. It's not definitive in that way. It may make it slightly more likely, but we have this thing called base rate neglect, where, well, we also have to think of the prevalence rate. Prevalence rate of OCD is only 1 to 2%, although in perhaps subclinical levels could be higher than that. But so even if genetics increase the risk by a factor of 2 or a factor of 3, it doesn't necessarily indicate definitively that there will be a case of OCD here. And if a parent has anxiety, I think it can be useful, again, for that role modeling of like, oh, sometimes my mind is playing tricks with me, or I'm getting the sense that something bad's going to happen, but I'm learning or I'm seeing that it's better to just go through with it, right? So something like that could be helpful.
Great. Sort of in the lines of what we're talking about, as a follow-up, I guess, if a child is showing compulsive behavior, is it better to try to stop it in its tracks as the parent, or is this something that you need to wait and address with a mental health specialist?
Yeah, so it's a great question, because actually we want to be careful not to over-diagnose kids, because especially in young kids, it's normal, very normal, developmentally appropriate, in fact, to have routines of like, I like the same bedtime story every night, or I like things to be a certain way, or I want it to be mom who tucks me in, or I prefer dad does this. So kids can have preferences and routines, and for the most part, kids sort of grow out of these. So I wouldn't want to overreact at first. But if you notice that patterns are becoming very, very rigid, there's no flexibility, you could try being flexible. Like, oh, well, of course, you prefer it this way, but don't you think it might be nice to try something new? And if you try that a lot and it's clear there's no wiggle room, or there's like very severe anxiety at disruption of routines, then maybe it would be good to contact a mental health professional.
Great. You've really touched on all of the questions, but people, I guess, are asking in more detail. If you wouldn't mind elaborating a little bit, exactly what you were talking about with regard to homework and procrastinating. Is there a way to try to stop this cycle? Because procrastination will lead to further anxiety, which will lead to further procrastination.
Yeah, so I think the first way to break the cycle is to observe the cycle, name the cycle, be aware of the pattern. Like, I've seen this road before. I know what will happen if I go down this path. Then when you're aware, like, I'm starting to procrastinate, we have these ideas of like, break it down into manageable pieces, like set aside time that you're going to work on whatever the assignment is in an increment that becomes doable. Okay, maybe the first thing I'm going to do is I just have to write the first paragraph. Or if it's a book, I just have to read the first 20 pages and like make it into, because sometimes the students are so concerned that they're so far behind that it feels like this mountain that they can't scale. So why bother trying? So we say, don't look up, just look 5 feet ahead of you, and you'd be surprised how far you'll make it if you just go 5 steps at a time. So we break it down into manageable pieces. And then we have a general behavior therapy principle. It's always better to encourage and reward and praise the behavior that you do want, rather than trying to suppress or punish the behavior that you don't want. So a series of rewards and punishments for, okay, well, if you can just get the first paragraph going and the ball is rolling, then, you get all the kudos, you get all the high fives. So that could probably be a good way to do it.
Great, thank you. Are eating disorders OCD, and are they related to anxiety?
So eating disorders are not classified as OCD. They're separate from OCD, but there can be some overlap. Often the overlap that could happen is in like factors that would go along with the eating disorder, such as perfectionism. Perfectionism could be seen in both OCD and in eating disorders, the tendency to have really high, rigid standards. That might be common to both of them, but they are sort of different. What can also happen in eating disorders are obsessions with food, like fears of gaining a large amount of weight for eating particular food items, or ritualized eating behaviors. But those are typically thought of as being a product of the eating disorder itself and not diagnosed as being OCD. So they are sort of separate.
Okay, great. This one is my question. Do you recommend meditative practices in conjunction with behavioral therapy? Is there any scientific value to meditation?
Sure. So meditation has lots of different uses. Meditation can be used as a standalone stress reliever. There's different forms of doing that as a way to cope cope with general anxiety or help with focus. But meditation is also included in some treatment packages, namely dialectical behavioral therapy and acceptance and commitment therapy, often treat people by training skills in mindfulness. And mindfulness, mindfulness can be done as a meditation or can be done as like a centering, focusing technique or a grounding technique. And that can be particularly helpful during times of heightened anxiety.
Great. Thank you again. And thank you to our audience for your amazing follow-up questions. And Dr. Wheaton, thank you for this incredibly detailed and informative programming. Thank you. Before we finish, would it be possible for you to just let us know the names of the courses that you teach at Barnard so that our students can know how to find you?
Oh, sure. So right now, this semester, I'm teaching my lecture class in clinical psychology, which used to be called Introduction to Clinical Psychology. Now it's just called Clinical Psychology. I co-teach a laboratory class that goes along with that, which is called Lab in Clinical, a research class that goes along with clinical psychology. In some summers, but not this coming summer, I teach a summer class in abnormal psychology. And in some fall semesters, I teach a seminar actually in anxiety and OCD that's mainly for juniors and seniors and can be used to fulfill the psychology senior capstone writing requirements. So that's mainly an upper level seminar class.
Wow. Thank you. That sounds great. Okay. Dr. Wheaton, unless you have anything else to add, we are going to thank you once again for this very insightful discussion and for keeping us aware of the things that we can be doing at home to keep anxiety levels down and to keep ourselves in check and figuring out how to help our children with anxiety. Thank you all for joining us tonight. And again, thank you, Dr. Wheaton. If you have anything to add, please.
Yeah, I just want to thank you so much for inviting me to come and talk to you all, but mainly to show off the work that the current students that I'm working with, because I'm so proud of them for their research ideas. And it's always fun for me to get to come and talk to groups of people about the work that we're doing at Barnard. So it was a pleasure meeting with you all, and I hope this will be helpful.
Thank you so much. This was amazing.
Okay.
Thank you.
Bye-bye.
Thank you. Bye. Thanks. Have a good evening.